Hi, this is John Kanellopoulos from our center here in Athens, Greece, the Laser Vision Ambulatory Surgical Center, Clinical Professor of Ophthalmology at NYU Medical School. We're seeing here a patient that I had done here in Greece. I had placed a secondary IOL on this eye that's traumatized. By the way, we're seeing now over 20 years later that he also has keratoconus. The fundus is good, but we saw a significant subluxation of a three-piece IOL, good cell count in the right eye. Uh, as I mentioned, we're here in action in surgery with a Kuglen and a Sinskey hook. I had placed back in 1997. It was at the time that I was visiting Athens, Greece, while working in New York City and Connecticut. And we're surfacing with those two hooks the lens into the anterior chamber. Of course, we've placed Viscoat to protect the cornea. Another intricacy of this patient is due to the significant correctopia. Back then, I performed dense green laser treatments on the iris to shift the iris um, towards the temporal side, shrink it, and thus create a pupilloplasty with the pupil opening more centrally. His pupil was decentered nasally. Of course, we don't have that video from back then. So I'm placing methicellulose in the backside of the lens. Due to the cornea astigmatism that we saw before, I'm going to enlarge the incision temporally and pull out the lens. It's a PMMA lens, so the incision has to be at least 6 millimeters. Not easy to cut this lens. We're seeing here calibers set at 6. So go ahead and pull out the lens, and then of course the options here currently in Europe is use a Carnevale lens with scleral support, a glued three-piece IOL, or um, what we'll see here, an artisan aphakia lens. Since there is good pupillary support superior and inferiorly, we're giving Myocoat to attain miosis, and we'll pull out our go-to lens for this circumstance with good pupillary support and use the lens also as a pupilloplasty tool, and we'll see how. So we're picking up the lens, inverting the lens to be placed retropupillary. I know this is off-label. Um, place the lens on the special forceps for this lens, and with my inclination needle now tilt the lens to have the haptics visualized through the pupil. I apologize, the visualization here is not great, but I'm using my inclination needle to get good hold, a good tuft of iris between the haptics of the lens. Now using my other hand, my left hand, and you can see here, visualize clearly how I'm going to tilt the lens with my left hand and come in with my right hand and the inclination needle and squeeze pupil through the claw haptics of this lens. And I had the fortune to have trained with the late Jan Wurst, who has had introduced this lens from Groningen, Netherlands, many, many years ago. And of course, a cornea surgeon's approach to this, placing nice radial sutures, and in order to reduce the potential induction of astigmatism. The biometry was done carefully. You need an element of luck here to see this patient 2 months later. As we will see shortly, I'm going in with my Sinskey hook, making sure there's no tag of vitreous anywhere, and we're clear. So the pleasant surprise is we're 6 weeks later. The patient is 20/20 uncorrected. We can see the result. We can see how the tucking the pupil has helped create a better pupillary aperture in the center. Although compared to the pupillary aperture, the lens does not seem to be well centered. Compared to the visual axis of the patient is perfectly centered, and the patient is enjoying 20/20 uncorrected vision. Of course, not always predictable, but this is definitely a happy ending to a long story, as this patient had to go two separate IOL procedures, one with a lens initially sutured in the backside of the iris with Prolene sutures. Subsequent trauma or melting through the pupil released that capture. Now we came in with the artisan aphakic lens to have a very good result. Thanks so much for your attention. I hope you found this case interesting. This is John Kanellopoulos signing out.